Well, we're starting a little bit late, but due to some technical issues, but let's go ahead and start. So, welcome and thanks for joining us this morning. Academic medical centers combine the best in education, clinical care, and research in one location. These facilities are a training ground for physicians and a destination for cutting edge research, treatment, and emerging technologies. Academic medical centers are also massive facilities that operate almost like cities within cities. The average academic medical center in the US has 526 patient beds, and they are spread across campuses with multiple medical and support buildings. Facilities of this size, complexity, and importance require careful planning to meet the public health needs of today and tomorrow. I'm Hunvey Chen, Regional Leader of Healthcare for HOK's Los Angeles studio. Over the next 20 or 30 minutes, I'll be leading a discussion on the evolution of academic medical centers and the unique demands involved in planning and successfully executing projects of this scale. We're happy to have with us today Jim Mladucky, Vice President of Design and Construction at Indiana University Health. Jim has more than 30 years of experience in healthcare planning, design, and construction, and is currently overseeing IU Health's more than $5 billion of strategic facility program. With that is the new academic health center, which is $4.29 billion of that total. Also joining us today are Scott Rawlings and Paul Strohm, directors of HOK's healthcare practice. Scott and Paul each has decades of experience planning and designing complex academic medical centers for institutions across the United States. Jim, Scott, Paul, welcome. We invite everyone watching on LinkedIn to also join the discussion. Post your conversations and comments in the chat, and we'll try to incorporate them into the conversation as time permits. So let's get into it. I'm going to start with you, Paul. Perhaps you can set the stage for us. When you're beginning the planning process for a large-scale project like this, where do you start?
Hunvey, thanks so much. Scott and I have really been working with Jim over the course of the last 5 to 6 years to help him and partner with IU Health to advance their program. To get started, I usually like to ask 3 questions. The first question is why? Why is the project really being done? It's usually tied, as you mentioned earlier, to the strategic mission of the institution. In this case, bringing together clinical care, research, and education into a single campus. It's clearly strategically important to, in this case, IU Health. IU Health is the primary leader of care in the state of Indiana. They serve over, I think Jim can clarify, but over a third of the population of Indiana. And this facility is really critical to the city, the state, and even the region. And I think, Hunvey, as you mentioned, these buildings are a place of last hope, and in some cases, just serious illness that many times there's really wonderful cures that happen. The second question is just what? What is really being done? And for that, we really need a leader, or in the case of IU Health, 2 leaders, and Jim is in fact one of those leaders on the design and construction, and he was paired with the president of the hospital. So you really want to establish a leader. You have to have a site. In the case of IU Health, we studied multiple sites. You have to figure out what the program is. You have to define the budget, and you have to get a schedule and understand what that's about. The third question is, how are you going to deliver this? What's going to be the process for programming, master planning, design, construction, and activation? And most of the time, it involves a multifaceted team of architects, engineers, consultants, and builders that work together as a collaborative team for the benefit of all the people who are going to use this project and for the client in a partnership of collegiality and really working together. And then lastly, as part of the how, is to define a governance and decision-making structure that will advance this. There's literally hundreds, thousands of decisions, some big, some small. You have to know when to make them and who's going to make them. And so it's an exciting it's exciting puzzle, a Rubik's Cube, on how to advance these projects. And we've had the great pleasure to work with Scott and I have, and other as our partners to work with Jim.
That's great, Paul. Thanks for sharing those four good points. And speaking of Jim, you had mentioned the leaders. And so, Jim, you are overseeing the project and the development of this destination medical center in downtown Indianapolis. Could you share with us the vision for your project?
Oh, absolutely. And again, thank you for having me today. I really appreciate the opportunity to share our journey at IU Health with everyone. So, yeah, our vision for the project is one, as Paul mentioned, it is truly an academic medical center that brings together clinical care, leading edge clinical care, research, and of course, education. And so we're partnered with Indiana University School of Medicine and Health Sciences divisions to bring that forward. Paul mentioned that we serve over 2 million people in this state. So we are the primary care facility and the only academic medical center in Indiana, which is unique to the Indiana to those in Indiana. So our focal point and our aims really were to consolidate the two campuses. Today we are about a mile and a half apart between what's Methodist Hospital and University Hospital. Bringing them together, creating a leading edge academic health center that enables research and finds cures and restores normalcy for our patients. We want to make sure we remain an established, nationally recognized destination for care, and we serve the most complex illnesses in the state. So people from across Indiana and the Midwest come to us for those services. Um, Ultimately, our goal is to make Indiana one of the nation's healthiest states, and it's a hill to climb. Right now, Indiana is, I believe, 42nd least healthy. So we are doing that through partnerships, both with our local community, our statewide community, and government authorities, and private partnerships to ensure that the best healthcare is provided and the leading edge research is continued here in Indianapolis and across the state.
Thanks, Jim. Those are some really great visions for the residents of Indiana. In terms of overseeing the development of, or sorry, the biggest challenges of developing the project, and it sounds like there's many being on multi campuses. How has planning and design addressed some of those challenges?
Well, I think the first thing that Paul had mentioned was we studied many sites. So this is really bringing the two campuses together into one location. And we looked at each of the campuses to begin with and where should this go, but we also looked at other areas in the city. So Paul was, I think, he had mentioned 5 years. I think he could probably trace many more years than that to actually get to that. We are going to move to the Methodist campus, which is just on the northern edge of downtown. We chose that, frankly, because of the amount of property we have here. And the School of Medicine also chose to come with us. So they are moving from their current location on the Indiana University Indianapolis campus to this location, which again is about a mile and a half away. Uh, so, that focal point or that initial planning really was to set the stage for us to grow here. And there is really a pre-pandemic and a post-pandemic effort that went on. Pre-pandemic, we talked a lot about Curve Two. How do we improve health and how do we, in a lot of ways, treat people where they are versus bring them down to the academic health center. Uh, Post pandemic, it's a little different. And what we realized, and probably knew all along, but the pandemic really put a light on it, and that is this is Indiana's location, its destination for premier care. And when the pandemic was, at its high point, we had every bed filled, and we were taking many more patients than we ever expected. And as the pandemic, started to ease, we realized that we have to be prepared. And so, post pandemic, we were looking at reducing the amount of beds that we have today, and transitioning to really a focused academic health center that was smaller in footprint. Post pandemic, that's not the case. We are building 864 new beds because of what we learned during the pandemic and the needs of the community and the state, frankly. So that's a huge change for us. So that consolidation to this campus, that post pandemic knowledge and understanding really created a it really put a point on flexibility and adaptability of facilities and how we can design so that as programs change, as we evolve, as needs in the community change, we can adapt to those. And it's probably, from my perspective, and then you mentioned I've been in the business for 30 years, practicing as an architect and also as an owner. I've There's always been this talk of how do we make facilities as flexible as possible. Frankly, I think HOK, Scott, Paul, and their team helped us focus and put emphasis on that, and we found a way to do it. And it's probably the first time I'm ever going to deliver a flexible platform of care that allows for us to change and morph over the next 50 years.
That's great information. And I'd like to expand kind of on that idea about academic medical centers seeing an increase in patients, because you're right, things are very different than how it was pre-pandemic. So Scott, I wanted to kind of get the architect's perspective on that too. So as Jim had mentioned, we're seeing an increase in academic medical center, the number of patients that are being treated each year. How does that increased demand impact design, maybe beyond the flexibility of requirements that Jim just mentioned?
Yeah, thanks, Hunvey. You're absolutely right. Volumes are going up at the major AMCs, and it's primarily because as our population gets, frankly, sicker, and it's not sicker just because they're getting sicker than they were a few, 15, 20 years ago. It's just that we know how to care for more now. It's more personalized. So at that level, the academic medical centers are going to take the lead in this country at treating those types of patients. That's why we're seeing the volumes increase. As Jim said, we need more flexible platforms, but I'm going to also look at the other side too. We're going to see more patients. We're going to have to create facilities that are more efficient as they get larger, but we really can't forget that the biggest impact as the patient volume rises is on the staff. We're in a critical place in this country. We don't have enough well-trained clinical staff. The stress and the pressure on them is increasing, and we're losing good quality people because of that. So, from a design perspective, we're going to need to start really embracing the idea of creating workplaces that are, this is the top 5 or top 10 place in this city you want to work. We need to train constantly. We need to support. We need to recruit and retain really good clinical staff. And we need to find a way that somebody feels, I feel great coming into work today. I had a great day, and I feel great leaving today. IU's done a great job of that during this project. Jim has a core team that is just focused on organizing the internal pillars, as we call them, the internal tracks, and we've coordinated those tracks with the typical user groups and the design of the building, so that everybody is embracing the design and really pouring ideas into how do we make a better place to work. And I think that's going to be critical as patient volumes rise, staff wellness and ability to do their work the way they want to do their work is going to be critical.
It's a great point, Scott. The staffing is definitely a challenge these days. So, staying on sort of the design focus, next question for Paul and Scott. What are ways that academic medical centers can facilitate innovation through design, particularly when it relates to synergies with research, training, and technology? I don't know who'd like to go first.
I'll jump in first from that's an interesting question. When you start to bring all of them together, I'll spin off of what I just started with. The growth of academic medical centers is really primarily around personalized medicine and our ability to treat more as we move into the future, and that's only going to continue. Medicine is advancing faster, obviously, than it ever has, but it's on a skyrocket projecting right now. So what we're seeing, especially in the academic medical center campuses, we're seeing more buildings embrace the concept of vertical integration of teach, treat, and research. So we're building more translational centers now. The new building at UPMC, the Vision and Rehabilitation Center that's about to open, embrace the idea that we're going to treat, we're going to do clinical trials, we're going to research all in one platform so that all of the minds wrapped around clinical care of vision and rehabilitation are in one place, doing all of their work and bumping into each other every day. It's getting around a table. I think we even know that in architecture. You can do a lot virtually, but getting 6 or 7 minds around a table for 3 days, face to face, creates the best work. Same thing happens in academic medicine. If we can treat and research and trial all together, all have lunch together, all bump into each other every day, we're going to advance that specialty faster. So that's one trend we're seeing.
And picking up on that, Scott, I think, Hunvey, one thing you mentioned the word technology, and I think one of the things that's been a revolutionary change over for healthcare in general is the increased amount of technology that is embodying and sort of infusing itself in all facets of buildings. It used to be people, we had imaging and then we had surgery, and beyond those, there wasn't a lot. And now those have expanded greatly, and the technology is reaching out to all facets of care. And so I think one of the things that we've spent a lot of time, and frankly, Jim and other owners spend a lot of budget on, is trying to predict what the technology and infrastructure is going to be in these hospitals to allow them to provide and adapt to the technology that will be invented and brought online to care for patients. So we're spending a lot of time in that thought and effort. The other thing that I think would be that a lot of clients, and Jim is one of them, are doing is innovating in the area of reduced energy consumption. Hospitals are historically one of the biggest energy drains for power, electricity, heating and cooling. And so there's a great effort by many institutions to greatly reduce the carbon footprint, to greatly reduce and try to even get to a point down the road where you can be, energy positive as opposed to energy negative. And there's things we can do today and that we're trying to implement and think ahead about how to position buildings to be effective in that way. I think one example beyond IU is we're doing a project right now in Michigan for the University of Michigan, a neuroscience tower and center that is going to be USGBC LEED Platinum, which I think will be the largest kind of facility like that in the country with the sophistication. And it's going to save lots of energy and meet the mission of the university in general. So those are just a couple of examples on top of what Scott said.
I'm wondering if I can just hit on three things quickly here. One is just to build from what Paul had said. So IU Health has does have, in fact, a very much a focus on sustainability. For this project in particular, I have to admit, we designed initially around carbon, and resources that we have today for our central utility plant. But we also looked at how can that transition to electricity in the future, and we've designed it such. We also have it solar ready and geothermal ready. So those things, and especially with what we're seeing now from the federal government, there is some relief that we would, as a tax exempt entity, would be able to capture. And so solar panels, for instance, are likely going to be incorporated into our design and change how our central service building might look. So that's one thing I wanted to mention. I think the other thing is, Scott had mentioned staffing, and today all of us are in some ways a staff crisis. I can tell you that we have many more traveling nurses than we have ever had through the IU Health system, and that's not unusual. I also know because as part of our system, we have regional hospitals and critical access hospitals, which we've invested in, but not everybody is. And so those critical access hospitals in particular are closing, and consolidation of services are going to larger hospitals that are in those regions. But getting care to patients in rural areas is going to be a challenge in the future. Where IU Health is looking to change how we look at that and how we can bring home or care to home, and we have a large focus on that. And then lastly, how do you create environments that are inviting not only to patients and their families, but to staff, that support them, that allow them to do what they do best, and that is provide care at the highest level of their license. And so relying on technology, yes, we're investing in that. We're also investing in facilities that allow for respite, that allow for views to the outside and daylight for staff, that create an atmosphere that is leading edge, that attracts the best and the brightest from around the country. Those are the kinds of things that we're investing in. And so by doing that, investing in our staff and in investing in our staff's future. So those are important, and we see it and we know it, and design makes a difference.
That's so true, Jim. I do like how the conversation's talking about how healthcare was maybe 10, 20 years ago is very different than how we're designing it today. But maybe if we can take it a step further, this question's for any of you guys. What can we expect from these facilities 10 to 20 years in the future? And Jim, you kind of alluded to a little bit. We've talked, home care. Um, is there anything more that you guys can think of? How do you see them evolving to meet changing patient, clinical, and research needs?
I'll go first, and then I'll let my colleagues follow. I don't know. That's the best we can do is bracket that, and that's why we've invested in what we've invested in, and that is a platform that allows for the most flexibility possible. The goal, one of our guiding principles, is adaptability. And the adaptability as defined by our CEO of the system, the least the least cost to change a program in the country. So that's a huge challenge again that we're looking to meet, but it comes down to what are movable and what are not. And so you start with a structural grid and you work from there and allow for that physical environment to adapt over time from what might be today patient care, inpatient care, to outpatient care, to clinical research, to bench research, to education, to officing. So, the cost of that is higher when the first cost of it is higher. The long term ongoing cost is lower because you've invested up front.
Paul or Scott, do you have anything to add about the future of design?
Yeah, I'll throw in. First of all, I completely agree with Jim. Number one is going to be flexibility. There's almost no reason to sit here and try to crystal ball where we're going to be medically in 15, 20 years. We'll get it wrong. Um, what we're going to try to do, I think, what you're going to see in complex academic medical centers is how do you plan for the future? You collect data and you respond to data. So we have now moved finally, 10 years ago we rolled our eyes at AI. Now we've blown right through it. AI is the ability to collect massive amounts of data and organize it, but we are now moving into the land of machine learning neural networks, where we can take that data and the platform can actually assimilate, decipher, and even make change on its own. So I think you're going to see buildings that collect data virtually behind the scenes and then respond to that data. An example is a medical system on the East Coast is using data collected through occupancy sensors and scheduling and staff movement in outpatient centers to find bottlenecks where patients are coming to exam rooms and backing up, and then identifying exam rooms that are on an hourly or a bi-hourly basis underutilized because of no-shows, and literally making scheduling changes on the hour to move people around and decrease the bottlenecks. That's a great example of a smart building collecting data and helping the staff respond in real time. We're going to see that type of movement if we start to outfit our buildings to be able to collect data at a real time basis. You're going to start to see change management on, frankly, on a quarterly basis instead of when you build a building. So I think uh, having buildings that can sense and collect is going to be critical for the future.
And
I think we're. Oh, go ahead, Paul.
I wasn't
Sorry.
going to add to that. I was just going to say that one of the questions in the chat box had to do with how do academic medical centers relate to the community, and Jim could tell an hour story on this one. But IU Health, when they started this project, there was sort of a desert around the project, and through their initiatives, they have really proactively reached out to the community, reached out to developers, reached out to organizations within the community to actually embrace and link to and partner with IU Health and the Academic Medical Center. It's all about making a place in the community so that the community can more be invited in as a place to come to, not just because you need care, but because you want to come there. There's housing developments underway. There's health and wellness trail systems underway. There's food locations and food deserts being discussed and implemented to try to help the wellness notion of really what is an academic medical center. Because you know, care providers would love nothing more than to keep people healthy and actually not have to have them come to the center unless it's for personal pride and they want to come, but not because they need care. So I think that academic medical centers are moving upstream to deal with people's health and the communities in which they live in to help us all be more healthy.
Well, remember what Dennis had said to you and I, right?
Yeah,
If this is merely a replacement hospital, we've failed.
right.
We have to change the health of the community. Today, the people who live around Methodist Hospital have an average life of 68 years old, and that's just not acceptable. We have to do better than that, and that's one of the things that we're doing. We're focused on. So
That's a really great goal. And I think that's a great way to wrap up the conversation because we are a bit out of time. But Jim, Scott, and Paul, thank you for a great conversation. I know I've learned a bit from this. I hope those of you who have joined us have also learned something new about academic medical centers and designing these complex projects. If you have any additional questions, please leave them in the comment section and we will try to answer them via LinkedIn. And if you haven't already, feel free to connect with all of us on LinkedIn or reach out directly if you'd like to chat. So thank you for joining and have a great day.
Thank you.